presentation will be primary amenorrhea managed with vaginal creation or fertility counseling. So now we all need to know what is puberty and how do we define primary amenorrhea when a girl should start period. So in order to define that, we need to know TMS staging, which is a Tanner's classification, that the puberty, 5 stages of puberty, level 1 to level 5. Level 1 starts with just development of the breast bud, and level 5 is when the actual menstruation happens. So primary amenorrhea we define when a patient has had stage 1 development or stage 2 development, which is just development of breast bud and just little bit more development of secondary sexual characteristics. So that is, she has entered that. That can start from age 8 to age 13. But if 3 years have passed from stage 1 and there are no periods, that is classified as primary amenorrhea. We should never think, oh, this girl is still 12. We need to wait 17 or 18. Still there is time. Some people just have delayed period. It's not like that. Because in order to save the girl and her mother from all this trauma, we need to understand that from stage 1, which is the first development of breast bud, it is 3 years we can wait. If 3 years have passed and there is no periods, we should label it as primary amenorrhea to save the agony of all that which can happen to the whole family. Or irrespective of all that, if a girl has crossed age 15, has no periods, we can also label her as primary amenorrhea rather than waiting a bit longer. Sooner the better. Okay, so we are talking about MRKH. The ovaries are normal, so all secondary sexual characteristics will be normal. But there are no periods, unfortunately, because there is no uterus and there is no upper vagina. Lower vagina may look normal. So could be huge implication with vaginal creation. So functionally she can function as a female, but obviously fertility is a problem. Unicornuate uterus. I think the commonest thing we all see in other practice is the heart-shaped uterus or bicornuate uterus or septate uterus. So these are fairly common. Maybe all of us have seen a case of 2. But sometimes it's unicornuate uterus. One side goes missing. There is only one ovary. No problem. If the vagina is patent and ovary is working, usually there is no problem. But sometimes there is a rudimentary horn on the side of a normal functional uterus. So that still has got a lining. So when there will be periods, if it is blocked, it can cause a lot of obstruction. It can cause a lot of cramps and can cause problem with obstructed labor as well. So leading to dysmenorrhea and pregnancy complication. Something happened? Light? Maybe disconnected. While this is getting sorted, we can talk about imperforate hymen and imperforate anus, because these are also quite common. Yeah, imperforate anus we will not see that, because when a baby is born, usually because it's not compatible with life, isn't it? It needs to be opened up. So usually they are taken by surgeons and they fix it quite quickly if they have access. So we can talk about imperforate hymen, which can be obviously neglected and it can present with primary amenorrhea. Again, it's a rather commoner problem. Sometimes there is pinpoint hymen and sometimes there is various malformations, can be managed very easily. Just a cross-shape incision, periods can be drained very easy, but should not be taken lightly because can be associated with other abnormalities. Just drink some water. क्या इंटरनेट पे इंटरनेट पे So odd, but it will do the job, so no problem. Septate uterus, if septum is little, again no problem. But if septum is a bit bigger, could be problem with early miscarriages because surface area is small. Um, Bicorporeal uterus, um, hemiuterus, aplastic uterus. So obviously there are other abnormality as well, again because of Mullerian duct fusion and resorption system. Now we talk about congenital anomalies of the cervix. So in the first place, it doesn't form, which is cervical agenesis. Cervical hypoplasia, cervix is there, but it's very, very small. Cervical duplication, surprisingly, this is quite common. We have seen quite a few cases where there are two cervices, all associated with Mullerian abnormalities. Back to kidneys, an interesting slide, various types of abnormalities which can happen. It's a good slide, you will all have handouts. So again, a pictorial representation of various problems kidneys can have. This is an important one for all of you, particularly to work in obs and gynae. So the normal hymen we can see, and there are various annular hymen, imperforate, microperforate or septate, and fairly common problem. Sometimes labial fusion and labia majora hypoplasia and asymmetry of labia, very, very common thing. We don't take it as an abnormal. In the NHS, if somebody would say, oh, my labia is a bit asymmetrical, can I get it symmetrical? It's not allowed. Any changes which are cosmetic, they are not allowed, they are not funded on the NHS, and sometimes they come in mutilations. We have to be careful. But I don't know whether it is regulated here or not. People can have designer labia or something.
These days, gynae cosmetology is becoming very popular.
Fashionable.
But, we don't.
Yeah, that's the right thing. Yeah. In NHS, it is very, very controlled. You cannot do any of these. Comes under cosmetics and it's not allowed. Okay, vagina, congenital anomalies of vagina. So longitudinal septum could be a problem. Obstructive hemivagina with the rudimentary part, and transverse septum, again problem as imperforate hymen. So various types of abnormalities. The take home message is to keep everything in mind, the possibilities of these abnormalities, and to reassure patients, it's okay, these things happen every now and then, and something can be done about them most of the time if it is a structural problem. So uterus diadelphus, so what happens? Actually there is failure of Mullerian duct fusion resulting in two uteri and two cervices, may cause recurrent miscarriage and preterm labor. So you have to remember these two things, recurrent miscarriages and preterm labor. So it has clinical implication. Bicornuate uterus, what happens? There is partial failure of fusion leading to two endometrial cavities. Again, higher miscarriage and preterm birth rate. Do we have recurrent miscarriages clinics here? Yeah. So something to keep in mind. Septate uterus, most common anomaly. That's what I said, the heart-shaped uterus, 30 to 35 to 40% of the cases, failure of septum resorption associated with recurrent miscarriages and managed with hysteroscopic metroplasty. So we are talking about vaginal septum, longitudinal and transverse imperforate hymen. This is repetition. And again, we are talking about cervical agenesis, double cervix, cervical stenosis. Again, we are repeating the same thing, imperforate anus, anal atresia, again managed by colorectal colleagues, not by us. But the main thing for you to know is rectovaginal fistula, because it can happen as a congenital malformation. Because we often think it is as a result of obstructed labor or gynae surgery, but it can happen congenital anomaly as well. So there is abnormal connection between rectum and vagina, and can develop obviously developmental factors or acquired condition. So these are some of the pictures, and one interesting condition is caudal duplication syndrome, where everything is two uteruses, two vagina, two cervices, and complete hindgut duplication. Does anyone know the association of caudal duplication syndrome with one of the commonest disease in India? So India is said to be the epicenter of diabetes. Yeah, it is the world leading country in diabetes. So much diabetes is here. So there is association of caudal duplication. So all of you need to know about this. The mothers who have diabetes, their babies are more prone to caudal duplication. So clinical implication and management, prenatal ultrasound, postnatal imaging and clinical examination, surgical intervention like repair of imperforate anus or fistula or imperforate hymen, long-term monitoring for renal function and reproductive health, especially if it is a male fetus, because the posterior urethral valve, they are fairly common. Counseling, early detection and emergency care. We are nearly there. Embryological processes are critical for normal urogenital and rectal development. Disruption leads to spectrum of congenital anomalies. Early diagnosis and tailored management are key to optimizing outcomes. Thank you very much.
Can I say something? We see the congenital anomaly cases, Mullerian duct anomalies very often. And we have been managing these cases, and all of us have witnessed almost all type of cases, rudimentary horn with functioning endometrium, non-communicating, communicating, and all those things. But my one question, as all the seniors of gynae department who are really good in their work, they are sitting here. If we get a case of biconjugate uterus or septate uterus, when should we decide that we should offer them a management? Unification or septal resection? And I think Shaheen will be more than happy to answer this.
Actually, if the patient is asymptomatic, not having any problem, there is no need,
need,
to go
yeah.
for any intervention. If she is having any problem, then we should go for
What problem?
like
Any problem define that though?
recurrent RPL, or if she is not conceiving.
So
I
if
can
she
say
has
recurrent
one
implantation
If
failure.
she has one first trimester abortion, then what should we do?
Actually, nowadays we won't wait for 2 or 3 if she's diagnosed with a septal.
One or
complete
septa and one abortion.
And we have the
First trimester.
We have the facility of doing the septal resection with the hysteroscopy. I think I will
With
go
one, we should go for it.
I'll go for it.
Uh.
I won't wait. She should have at least 2 or 3. Then I'll decide for septal resection. But if we won't have facility and she cannot afford the treatment,
Then Shine, my question is like, as we know that most of the first trimester abortions are due to chromosomal abnormality, and anyway 15 cases out of 100 are going to abort in first trimester, and the one who have first trimester abortion are fairly possible that they will have a normal outcome in second pregnancy. So how should we decide at that point of time that with one first trimester abortion, we should take a decision of doing a septal
actually, we
resection?
will not diagnose the septum. Actually, for diagnosing, we should go for 3D or 4D. Nowadays, I think 40% of gynecologists is having 3D ultrasound. And they just do the 3D part and they detect. If they have the facility and patient want to go for the septal resection, yes. Otherwise,
If she has left it on you, what will you do? Like if she has left it on you with one first trimester abortion, what will you do?
I will not go for any investigation.
It may be it came out to be a septate uterus because she had an ultrasound while she was pregnant, and they said that it is a biconjugate uterus, although it was an abdominal. Now with her endovaginal sonography, the diagnosis of a septate uterus is made. And she has been advised MRI, further investigation.
Actually, with normal 2D, it is very difficult to diagnose septate uterus. 3D is required. And if she has gone for that, like higher center, just for one abortion, I think that counseling is required. So, after even with the septum, with the biconjugate uterus, first trimester abortions. Usually the second trimesters are more with these anomalies, but the first trimester abortions patient may develop first trimester abortion.
Yes, I do remember, and your patient had 13 abortions. By the time she reported to her, already she had 12 or 13.
13 and after the septal resection, she conceived and delivered.
And she delivered also.
And I think in last OT She came with the 5 first trimester abortion, and it was a just biconjugate uterus. Ideally, we should go for metroplasty, but I did the partial metroplasty with the resection only, with the like through cameras with laparoscope and hysteroscope, and now you'll see the result. There may be a chances of rupture during pregnancy if we are doing some like intervention in biconjugate uterus. Even we'll go for metroplasty, it increases the rupture chances.
Exactly.
So with the conservative, I tried. Let's see what will be the outcome.
Would you like to
add one
yeah.
point only? Because there was a discussion going on that with one abortion you have to can wait, not to go for other investigation. But I think if we have to take into account the other factors as well, like in this era of the more the females are pursuing their career, so they are of advanced age. So if she's age is more than you have to, it's one abortion, then she should be investigated.
Yeah.
That is my question.
So that's a very valid point. In the UK practice, there will be no investigation unless there are 3 recurrent miscarriages. No investigation at all, because resources are very precious.
These are
So,
the cases which certainly puts you under dilemma.
exactly.
Yeah.
Yeah. So 3 miscarriages only, then they get referred to recurrent miscarriages.
And then of course,
Yeah.
it's a threat.
Yeah. So when they have
So many things that you have to consider, like the gestational age, the
exactly.
time of abortion,
Yeah.
everything.
Yeah. But in the 3rd miscarriage, the products will be sent for cytogenetic analysis with the 3rd miscarriage. So when they go to recurrent miscarriages clinic, result is available if there is any mutation or anything.
Now, Ashley said it's after 2 abortion, you should go. So nowadays we are going, we start investigating the patient after 2
Yeah,
abortions.
that makes sense. 3 can be very traumatic, but that's how it is in the UK. So
but now with the era of ERT, even with the implantation failure, we are being considered as a, it's a like if the patient is, there is a problem with the 2, there is no implantation after 2 embryo transfer, so we start investigating the patient accordingly.
yeah, that makes sense. But metroplasty itself is a very traumatic surgery, and itself can result in infertility.
Infertility, yes.
Exactly.
So that's
Exactly.
why
Adhesions, Asherman syndrome, you name it. Okay. So is there any questions from the audience about anything we talked about? And don't feel shy, you can ask in Urdu or no need to be shy. No questions?
You told that in your slides that there are two bilateral kidneys are congenitally absent. That is not compatible with
yeah. So we were just discussing the spectrum that could be serious anomalies not compatible. Yeah. Yeah.
These days we are,
Exactly.
these days we are able to diagnose so many things in intrauterine life. Like previously they used to diagnose it later on, but now almost
things
most
are
of the
getting
things
better,
are diagnosed.
unless patients are completely unbooked, as it could be in your practice, isn't it? Okay, shall we move to the next?
Even if they are unbooked, they will have an ultrasound.
Okay.
These days it has become so rampant. Ultrasound zarur hoga, chahe antenatal visit now.
Okay. Okay, I think considering time, should we move to, let me see which one is the next one. Sorry about that. So now, this is the one next lecture, isn't it? Okay. So should we move to the next topic? Yeah? So we are talking about neurophysiology and pharmacology of the lower urinary tract. Hmm?
I think we can start, we can have tea.
We will have a break at 5 o'clock. Yeah, sure. We will have a tea and then yeah. Okay, let's finish this. This is very brief. Yeah. So we are talking about neurophysiology and pharmacology. This is another thing which as students we are scared of, isn't it? It's not a very nice topic. It's difficult to understand. So I made it very simple. So what do we want at the end of this lecture? That all of you understand what is the neuroanatomy very briefly and very simplified, and we are only talking about in reference to urogenital system, not the whole neuroanatomy, and neural control of lower urinary tract, which we can refer to LUT. LUT is abbreviation of lower urinary tract. So we use that a lot. And also we understand what is the storage phase of bladder and what is the voiding phase. That's all you need to understand. What is the storage phase, what is the voiding phase, yeah? Understand key neurotransmitters and receptors involved in LUT function. LUT means lower urinary tract. Discuss evidence-based pharmacological and non-pharmacological management of LUT dysfunction in gynecology, and we will refer to RCOG and BSUG guidelines. So, very basic things and relevant to urogynecology. Sorry, busy slides, but it is just the basic anatomy, neuroanatomy. So what we are talking about here, that bladder, urethra and pelvic floor, all these together, they are responsible for storage and voiding phase of the urinary cycle. The integrated function of these components of LUT is dependent on a complex control system. Mind you, it is really complex. In the brain, spinal cord and peripheral ganglia, and on local regulatory factors. So bladder is one of those organs which is very strange. There is no other organ in the body, if I am not wrong, which is controlled at so many different levels from head till our pelvis. So we are talking about cerebral cortex, we are talking about brain stem, we are talking about pontine center, we are talking about spinal cord, we are talking about pelvic subplantar nerve, we are talking about sympathetic system, parasympathetic system, and if this was not enough, the local nerve control as well. So it's a very, very rich organ. But if you look at the bladder, it is such a flimsy organ. It is nothing, isn't it? So that gives it very, very unique characteristics. It is rich in nerve supply, but in structure, it is very, very forgiving organ. There is no other organ which we just injure and repair and it gets along so well without even any scarring. So in a way, it's an excellent organ. Okay, so we are talking about dysfunction of neurology or component of the LUT. They can either produce insufficient voiding and retention of urine or different type of urinary incontinence, complexity in overactive bladder. So all the neuronal control is that when we are storing the urine in the bladder, the storage is good. And when we want to pass it, it should be complete passage of urine. So there should be no insufficient passage, so there should be no retention. And when we are storing, it should be a perfect storage without any leaking. So the bladder has two phases, storage phase and voiding phase. That's all at this stage you need to remember. Failure to store urine can be improved by agents that decrease detrusor activity, yeah, and increase bladder capacity and or increase outlet resistance. So what you have to remember, the name of the bladder muscle is detrusor muscle. The thickness of that detrusor muscle is hardly few millimeter in a normal bladder, and it is very pliable. So if you think about a normal balloon, when we put air in the balloon, it becomes even thinner, yeah, and we can fill more and more air and it will be very forgiving, yeah. But what happens in overactive bladder, there is a problem in the detrusor muscle, so it becomes thicker, so it's not able to distend. So we will discuss that why does that happen, yeah. So that is a problem with the storage phase, and then we will see why the outlet of the bladder, which is urethra, what are the factors which make the urethra incompetent. So urine gives way and people have stress incontinence. We'll talk about it. We will also have a brief overview of the nervous control of lower urinary tract and some of the therapeutic principles. We'll talk about common medication which we can use to help. So again, we are talking about neuronal control. It occurs in response to afferent signals from lower urinary tract. It will be a nice pictures, I think, rather than reading from here. We will go on. But what it says all, that there are 3-4 levels starting from the brain stem, cerebral cortex, spinal cord and pelvic splanchnic nerve. So when there are injuries or diseases of CNS, only then we come to know that these voluntary control of micturition can be disrupted. So what can be these injuries or diseases which can affect the passage of urine? Any ideas? Very common problem. Stroke, yeah, neuronal disruption, multiple sclerosis, yeah, sometimes Parkinson's, yeah, spinal cord injury. So these are common conditions which can result in disruption of these neuronal signals. Either they result in severe overactive bladder or urinary retention. So we are talking about various neurological conditions briefly, and also problems in parasympathetic nerves, sympathetic nerves, and pudendal, which are local nerves. So let's move on. So this is the anatomy of the lower urinary tract, which Dr. Nassim beautifully mentioned as well. So bladder has detrusor muscle. We have to remember it's a smooth muscle. Any other example of any smooth muscle in the body? Any of the students? Very good. Can we control smooth muscles? No. But bladder we can control, can't we? Yeah? So contradiction. Yeah? And also it can become overactive. Can any other muscle, smooth muscle in the body become overactive? It's different, isn't it? It's a very strange type of muscle, isn't it? It's smooth, but it has some voluntary control. Yeah? And it can be under control, it can be out of control, and it has so many factors which can affect it. That's why it's quite an interesting organ. But what we have to remember that detrusor is a smooth muscle. Internal urethral sphincter. It's a smooth muscle too, and it is involuntary. We are talking about internal sphincter. Where does it lie? At the level of bladder neck. So we can't see it. External urethral sphincter, which is skeletal muscle. So it's different. So where would it be? It is in the pelvic floor level. Yeah? So it is a voluntary muscle. And innervation sources of bladder are parasympathetic, sympathetic, and somatic nerve. Any idea what parasympathetic will do? Would it be storage phase or urine passage? Parasympathetic, would you say? Yeah? And sympathetic? So, easy thing to remember, sympathetic is fight or flight. When somebody is fighting or fight or flight, or worrying about something, they forget about their bladder, isn't it? So that's the easy way to remember. Sympathetic is usually storage and parasympathetic is passage, isn't it? P and S, then you remember. Neural control of bladder, we are talking about brainstem, pontine micturition center, coordinates urination, and cerebral cortex is voluntary control. We all know, oh, is this the place to pass urine? It's not, so we control it by our cerebral function. Spinal reflexes are sympathetic dominance in the filling phase. Okay, so voiding is parasympathetic, which is the emptying phase. So anybody with stroke or spinal cord injury can have retention. Again, we are talking about the level now. What level? Sympathetic control. So as a student, you need to know T11 to L2 is the hypogastric nerve, and then beta 3 adrenergic receptors, they cause detrusor relaxation. So what you have to remember, beta agonist, yeah. So beta agonist is good for bladder because it will help with the urinary incontinence because it relaxes the detrusor muscle, so storage phase is improved. So alpha 1 adrenergic receptors, they act on internal sphincter contraction, and then pudendal nerves, which are local nerves, somatic control, and then external sphincter contraction. So all these are levels of various receptors which act in the blood pathway. So voiding phase is parasympathetic. So remember P for passage, yeah, and then you will remember is parasympathetic. The level is S2 to S4, yeah. M3 muscarinic receptors cause detrusor contraction, and inhibition of sympathetic and somatic nerve is sphincter relaxation. Again, it's a nice picture. You can refer back to it with sympathetic, parasympathetic, somatic, and sensory levels and all the information there. So storage reflexes are distension of the bladder produced by afferent firing in the pelvic nerves, inhibition of detrusor muscle which causes relaxation, increased tone of bladder neck and urethra, and pudendal outflow to external urethral sphincter contraction. So that is the storage phase. As I said in the beginning, all you need to know, two phases, storage and void.